Thank you. So, look a little bit strange. Why did we talk about visual fields and then surgery and then OCT and imaging? But maybe it was because we wanted to break it up a little bit. Of course, you're going to do all these amazing new things that Sheng does in his clinic, but first you need to know if your patient is getting worse or not, which is what we're going to talk about today with regard to imaging. No financial disclosure with this talk. And this is, again, a continuation from yesterday's topic about the management of glaucoma. So I am going to focus on what tools we have, and I'm going to give you some clinical examples from my clinic, everyday glaucoma patients. We know very well that the structure and function in glaucoma do not correlate very well. It's complex and it's falsy. So we all see these horrible looking nerves with beautiful visual fields and vice versa. For the same reason, you need both structure and function to monitor your patients. At the end of the day, there are some people who cannot do visual fields, or they are very bad at it. And then, or they may not be able to do them at all because they don't speak the language, or because they have arthritis or ankylosing spondylitis. So there are many reasons why you need imaging. In an ideal world, you need to have both. If I were in front of a dilemma to choose between the two, I would personally go for the field, but because it reflects more what the patient sees. But if you can have both, that's fantastic. So over the past several years, we've seen the GDX, the HRT 2 and 3, we've seen OCT, time domain, spectral domain OCT, and these are no longer commercially available. The problem with that is not just that you cannot buy them anymore. The problem is that because they are not available, the companies will not update the software. So while technology evolves, these machines cannot evolve. However, these have been around for a long time, and most of the tests that we have, at least at Moorfields, are with previous technologies. So we do now use the spectral domain OCT, but we don't have long years of follow-up, which is why I'm going to show you some example of how we use imaging for monitoring with the HRT and some examples with the spectral domain OCT. By the way, I do still use the HRT in my clinic because if my patients have had HRTs for long and I don't have OCT baseline for them, it's more useful to have the HRT. So what we do for a couple of tests, we'll do both, and then we'll abandon the HRT and move on with spectral domain OCT. So spectral domain OCT that we all know and love gives us three-dimensional volumes of the disc, the macula, and the retinal nerve fiber layer, and relies on normative databases, which basically means that if your patient is different than the normative databases, he or she will be classified as abnormal. Not necessarily glaucoma, but abnormal. So these are the four printouts that you get for monitoring from the four commercially available OCTs. And we know from the literature that these are equivalent. This is a report from the American Academy of Ophthalmology, which evaluated all of the four and concluded that they are all equally good and useful, and they should be used for diagnosis and monitoring. And then you have this new ganglion cell complex parameter, which is very useful for detecting early glaucoma, but also for monitoring advanced glaucoma. Because the OCTs have a reference plane below which it cannot work. So if your patient has a lot of glaucoma and the retinal nerve fiber layer is already very thin at the level, for example, of the nerve, it cannot measure whether it doesn't get any worse, let's say. So you need to have a different kind of measure, and the GCC complex gives you that. Detecting changes with the OCT is basically about detecting change which is greater than the expected variability from one test to the other. And as we said with the visual field, the same concept applies: event-based analysis, trend-based analysis. But you need to remember that the machines are not interchangeable. So if you move practice or if you decide to buy a better OCT from a different manufacturer, you cannot transport the tests from one to the other. You need to start with the same one and stick with that, which is why it doesn't matter which one you use, as long as you use the same device. This is the printout from the series OCT. So at the top, you get the two tests will give you the baseline. Next to that, you get your following tests. You are going to get change probability maps, exactly like the visual field color map for likely or definite progression or change, increase. You may have an increase in the retinal nerve fiber layer, for example, for other reasons. And then you get trends of all these indices. I would say that, oh yeah, there it is. So, for example, if something is highlighted as red, its likely loss suggests that you may have true change. But again, you are looking for clusters. But these, of course, need to be interpreted in the context of the rest of the clinical information. So if this is getting worse, but the disc to you looks normal, it may not be abnormal. The disc may not be abnormal. It may not be glaucoma. So all of that needs to be interpreted with a visual field together and with your clinical examination. And then also, together with the graphs, where you get numbers as well, clinically, maybe not that useful, but if you want to measure these, even for research or audit, then it can be very useful. You also get color-coded there. So basically what that means is that your retinal nerve fiber layer thickness changed from that to that. At the time, the machine said, possibly worse. But when the second time it went there, it was classified as likely worse. This is progression. A very slow one, but it is progression. And then at the second page, you get a set of parameters where abnormal values are highlighted. It's worth spending 5 minutes reading this printout because it does give you all the information that you need. It tells you exactly what this means and what that means. I'm not going to read that to you. But these printouts are meant to be self-explanatory for an ophthalmologist. This is the TopCon, very similar approach. You have your baseline here, you have your follow-ups, you have your trends, and again, your indices there. This is the one from the RT view. You get the graph from the macular complex. I was saying yesterday that the printout from the GCL gives you this donut at the level of the macula because 50% of the retinal ganglion cells are at the macula. So it's a thicker layer, which is why it's so good to measure glaucoma. And you want the donut to be whole. In the middle, you get the graph for the RNFL analysis. And again, at the bottom, you get the graphs. It's the same logic, whichever OCT you use. Spectralis OCT, very simple, gives you a plot of the retinal nerve fiber layer over time. I'm going to mention a few words for the HRT because some of the examples have the HRT and because some people still use it. For diagnosis, it uses two different scores, the Morphy's regression analysis and the glaucoma probability score. You get a lot of measurements here. You get ticks and question marks to highlight normal or abnormal or borderline. But what you need to remember is that for diagnosis, it's not very good. None of them are. For progression, they are very good. Detecting change with the HRT, very sophisticated graphs that's probably nobody reads. And then you get change probability maps with red highlighting the change. But the most useful analysis with the HRT, if you use it, is the topographic change analysis. And here is a very nice real example of a disc getting worse and how the rim is gradually getting thinner, which is why you get this red area. Counterintuitively, in the HRT, when the graphs are going up, the patient is getting worse. And you may get a lot of green color as well, but that's most of the time artifacts. This is an interesting example which shows you how HRT and all of these machines can detect change, but may not detect glaucoma necessarily. So this is a patient with a disc which is clearly getting worse. And this is very, very typical glaucoma getting worse. But if you look at the analysis algorithms for diagnosis, both the Morpheus regression analysis and the glaucoma probability score classify the disc as either normal or borderline. So what's happening there? Well, what's happening is that your classifier is not good enough, but it is good enough to detect change, which is why it is worth repeating the tests again and again. People sometimes think that it's the other way around, that I will do my imaging at baseline and then follow my patient with a visual field. Of course you need the visual field, but imaging is more useful for monitoring the patient, not for diagnosing the patient. Some clinical examples which I personally thought were interesting from my clinic. So a 63-year-old male with high pressure and suspicious discs referred to the clinic. No ocular history, but he has a family history of glaucoma. So the pressure is high. And this is the HRT, and this is the field. Now, the HRT here says it's borderline. This is our baseline. The HRT doesn't classify this disc as abnormal, but the visual field is very typical glaucomatous, and it was confirmed. So this is glaucoma. The left disc is normal, and the left visual field is normal. So obviously no comments, because I made all the comments. This is how the patient did over time, and this is a graph that Medisoft, which is an electronic patient record, generates. A few interesting things here. One of the interesting things is that nobody gave a prostaglandin analog to this patient. They gave brinzolamide and brimonidine, but nothing like latanoprost. But anyway, so the pressure is running in the teens in both eyes, and now the patient is in the right eye having 2 or 3 drops, in the left eye monotherapy. This is the pressure. And this is the HRT. This is the example that I used for the printout. This disc is clearly getting worse. What would you do? Anyone would do surgery? Add the prostaglandin. Great, okay, let's talk about that for a moment. So the pressure is about 24. Oh, I'm sorry, by the way, he is taking prostaglandin now. Sorry, you are right. Yes, they are. So it's not an option. Would you add a beta blocker, maybe, for this patient, if you could? Very good question. So he is on bimatoprost, and that is probably dorzolamide, which was changed to brinzolamide. So I assume that they cannot have a beta blocker. That's why they didn't give that. The other eye is only on bimatoprost. So basically one can add an A2 agonist, like alphagon, right? Yeah. And if you can add a beta blocker. Anyway, I think that this patient probably needs surgery, because this is a very capped disc, and this is how the visual field looked over time. But the bottom line is that in this case, even if you didn't have the visual field, you would know that this patient is getting worse. And there are cases where you do not have the visual field, and it is confirmed. So when we got the OCT in 2017, we monitored the disc with the OCT, and it was also confirmed with the OCT that this patient is going down fast. The bottom line, though, is that when you add a drop to somebody who's getting worse, you need to know what it is you're expecting to get from this drop. It's not about adding the drop, it's about how much reduction are you expecting to get from the drop. If your pressure is 20 and you expect a 20% reduction, it goes down to 16, which is the best case scenario. Are you happy with that? Most of the times we're not, because glaucomas getting worse like that need pressures in the low teens, below 14 or even less, which is why you need a trabeculectomy or one of the amazing procedures that Sheng does, assuming that they do better, which they don't. This is the other eye, which has not gotten worse, and there is no progression, and this is very nicely confirmed with the HRT. Here's the thing, though. Oh, right, based on that, would you give something else? This patient is only getting I think Lumigan or something. Would you add something to this eye? And would anyone add anything to the treatment for this eye? 24. Same patient, the disc says, the disc is classified as normal, the pressure is 24 on the drop, and there is no change in the disc, and there is no change in the visual field.
How old is the patient?
The patient, I think, is, what did I say, 60, sorry, I have to go back to check, 63. I didn't give you all the clinical information, and it's not fair. I was trying to make the point that if your pressure is good, if no matter what the pressure is, unless it's very high, and you have a long follow-up over time with the patient not getting worse, you don't have to do anything for this patient unless you have very good reason to worry about that patient, like a disc hemorrhage or a pressure which is extremely high. With the OCT, it looks as if this patient may be getting worse. So if you knew that from 2017 to 2019, would you perhaps add something to his treatment? It's debatable, because if you already know that he's been stable on that pressure for 10 years, what makes you think that they are getting worse in 2 years? I would probably watch, maybe a little bit closer. But then again, it's something that you would have to discuss with the patient. And if the patient feels insecure about that and feels more confident adding the same treatment to both eyes, that's also very acceptable. The message I'm trying to get across is that pressure does not define our clinical decision-making that much anymore if you have this level of confidence in your tests, because it's about structure and function. Another case, that is one of, if it is, oh no, it's not the one I really like, but I'll show you that as well. A 77-year-old female Asian lady who doesn't,
Is there a lower acceptable limit regarding the intraocular pressure? Because I thought that according to the ocular hypertension, if I remember, for something like 24, 20, you don't want, even if everything is normal,
right,
you don't want it to be more than that.
okay. Yeah. According to the ocular hypertension treatment study, there is no threshold. But clinically speaking, you don't like a pressure being over 30, which is why, because then you're worried about other things, like CRVO, for example. So in this case, you treat the patient and you explain to them that it's not just the disc, it's other things as well. So there is no cutoff. Glaucoma is different, though. There is a cutoff for recommending treatment in in a patient with ocular hypertension. But then again, one may say, but if the CCT is 650, maybe I wouldn't treat. So there is no yes and wrong. The recommendation is that if it's over 30, you need to explain that you're worried about the retina as well. And then they can decide, or you can decide. Below that, there is no threshold. But glaucoma is different, because glaucoma may start with pressure of 50. So if your pressure is 50, let's say, for example, a secondary glaucoma, the pressure starts with 50, you bring it down 50%, 25, and there are many young people like that, uveitis, steroid risk, they do fine. You don't need to be overly aggressive if nothing is changing. But of course, the less confident you are, the more you're going to rely on the pressure. The second case is a lady, 77-year-old Asian, who speaks very little English. She was referred because of a suspicious disc and high pressure in the left eye. The patient is asymptomatic. So the son says, my mother doesn't complain about anything, but the father had glaucoma. And this is the visual field. Would anyone like to comment on this field? Do you think it's consistent with the nerve? How many people think it's consistent with the nerve? It's a bad disc. I mean, there is asymmetry, looks very cupped, looks a little bit pale as well. I didn't tell you what the vision was, of course. The vision was very good, though. The vision was 6/6, which doesn't make sense. It doesn't really make sense, all of that, especially in a lady who doesn't speak English and has the test at Moorfields. So, and is asymptomatic, right? So we're doing the test again. And we've cured this mysterious glaucoma. The disc is abnormal, of course. It's not a normal disc, but the glaucoma is not that bad. Important to make sure you have a proper baseline. So if something doesn't make sense, you have to go back and examine again. And again, the retinal nerve fiber layer from the OCT is abnormal in the left eye, which is consistent with what we're saying, because this nerve has thinning here, and thinning here, and thinning here. It doesn't look very pale to me, but I'm suspecting that it's probably because she has a cataract or something in that eye. And this is her OCT, the few tests that she had over time, and it is stable with the treatment that she's using at the moment. So this is an example of, this is an example of the Zeiss OCT, where you get your baseline to follow-up visits, change probability map, nothing highlighted here, and the graphs are horizontal. You don't have a lot of graphs, but we do have 4. Every test, every point represents a test. So this is a lady doing well. And actually what happened was she fell asleep when she had the second eye done. A third case of, I think this is the one I really like, 59-year-old female referred for suspicious nerves and normal discs and normal IUP, no ocular history, no systemic diseases, no nothing. So I saw the patient many years after she was referred, but these were the baseline tests. So the baseline test is abnormal in the left eye and suspicious in the right eye, according to the glaucoma probability maps. And then 2 visual fields which are sort of very strange. I mean, they don't really look glaucomatous. There is a missing part here. The grayscales can be very unreliable, but they give you an overview of what's happening. Do you think this could be glaucoma, knowing that the nerves look like that? Could it be? 50% chance of having the correct answer? Yeah. Could it? Yeah, maybe? Okay. Yeah, they were very worried at the time about the visual field and the disc looking very suspicious, so they gave treatment. And with the treatment, this is what happened. Is this patient getting worse? Yeah, probably. I'm sorry? 77, 75. Yeah. So that's what everybody did think. She's getting worse. And then she wasn't getting worse. So that's very strange, because this looks a lot better than this. This looks even better than this. But then she got worse again. And then they thought, okay, maybe there's something at the macula, because it's abnormal. But there was nothing at the macula, because we scanned the whole thing. We asked for MR advice. And of course, it's very easy for me, standing here in retrospect, to tell you that this patient is fine or is not fine. But at the time, you don't know what's happening. And then this is the last visual field test that she had in 2019. So this is an example where imaging is really useful, because this patient is not very good at doing fields. And this is her imaging. So this disc is not really getting that worse. There is an area here highlighted as worse, so there may be a little bit of progression. Her graph is relatively flat with a small change there. I would not call this HRT, though. I wouldn't really be concerned about this OCT. And this lady did not undergo surgery. She stayed on treatment. And this was her OCT. So the field was consistent with the OCT and she does have a superior NFL defect. But she was stable, and that was also confirmed with the fields at the time. I'm sorry, I'm trying to find her. Yeah, excuse me, can I go back? Yes, I'm sorry. So the progression algorithm, the visual field, picks up only 1 point, which is getting worse. It doesn't pick up a lot of change in this patient. There is nothing to suggest that this patient is getting really worse. And one of the things we're asking is not just whether there is any change. Okay, maybe there is a very small change. Is this change significant enough to affect this patient's vision within the next 3, 4, 5, 10 years? If you watch her, is she at risk of losing vision? And the answer is no, so we didn't do anything about that. And her other eye was also very similar, with visual fields that we didn't know what happened: abnormal, worse, 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 better, worse, strange, and a disc which was not getting worse. And the algorithm does not detect progression. So this is an example of where you cannot fully trust the tests. They are very good guides, but you have to consider who this patient is in front of you. So a patient who tells you that she hates the field, she is using drops, very bad at it. I'm not getting worse, I'm absolutely fine. Her pressure is good, there's nothing in the disc to suggest there is change, is not getting probably worse. And the OCT is also flat, this patient has not progressed. Thank you very much.
Thank you, Panagiotis. Thank you for your excellent presentation. Now we are ready to accept your questions. No? Please.
I'm a bit frustrated that actually we may pass the message that somebody who has ocular hypertension can go around with 25 blood pressure without being naked. Well, I remember that OHTS study had 11 pitfalls. It had mistakes. If you remember, it was saying that diabetes was a protective factor instead of against. Okay, and the European study came 2 years afterwards saying that actually that was wrong. And you remember they have distributed the general ophthalmologists this kind of thing that actually they were pushing on the button to just decide whether they were giving treatment or not. I tend to give my ocular hypertensive patients treatment to get them at some stage below 20, whatever pressure would be that, to be safe, to probably do an SLT. And it's certainly wrong to overtreat the patients. Pate was always talking about that. And also we know how much damage can the drugs do over time, because once these patients will become glaucomatous and you will need to treat them with trabeculectomy, then they will be fibrotic by that time. Okay? But I'm a bit frustrated that actually we passed the message, if you have 25 of pressure, you can leave the patient, just follow him. I wouldn't be, I don't feel very comfortable with that.
I'm sorry, if I may clarify, because if there is some confusion, I'm the one who created, obviously. But are you referring to ocular hypertension now, or are you referring to glaucoma? Okay, right. So I would like to clarify. What I said is that the ocular hypertension treatment study, which obviously is a study, so it does have flaws, did not really set a threshold for anything. Yeah? Okay. So it created a predictive model in combination with the European Glaucoma Prevention Study, where it calculates a risk. And depending on that risk over 5 years, you discuss with your patient whether they should be treated or not. But for the same reason, regardless of the level of the pressure, unless the pressure, of course, is 45, you may have a patient whose clinical profile does not suggest that they do not need treatment if the pressure is 25 or 26 or even 27. Because if it is a younger patient with very thick corneas, with optic nerves which look absolutely normal, and who there's nothing else, yeah, they can be monitored for a number of years without treatment. Things are very different in glaucoma, though, because if the patient has glaucoma, pressures above 20 or 24 are going to be bad for the patient. So the bottom line from my point of view, based on what we know from the literature, is that it makes sense to treat someone with a pressure over the 30 no matter what the clinical profile, unless the patient is really resistant to treatment, and then you may watch them. But, and that is not based on the literature, the 30, it's what we feel safe about. And for pressures below that, you follow a personalized approach depending on who the patient is. But yes, you can have patients with high pressure below 30 who are untreated. Sheng, would you agree with that?
I agree with what you say completely. I mean, one of the most common thing I do, seeing a new patient who has been treated somewhere else that come to my clinic, is a lot of the time I stop the treatment. Because there are lots of patients that have been overtreated with ocular hypertension, unnecessary, as you rightly say. I think it's really important that we make clear to our colleagues here that do not overtreat patients. And I agree. I think we have to emphasize the point about ocular hypertension, that if they have no risk factor, pressure is relatively low, as you say, under 30, you can just watch them without treating them. I completely agree with you. Yes.
Yeah, I'd like to concur with that. When we have lots of patients in the clinic who had the benefit of looking at the optician's referral years ago,
Yeah.
and we've seen so many times being referred 2 or 3 times, and had a period of observation of 2 years each time, and then being discharged again. So you have lots of patients who do very well and with ocular hypertension for a number of years. Okay, some of them will progress, but at least you save them from unnecessary treatment, which is a significant burden, both for the ocular surface and for their lifestyle. So yeah, I would totally agree with that.
I would also like to clarify something else, if I may. Of course, you have excluded exfoliation, pigment dispersion syndrome, and any other secondary causes. The other thing is asymmetry. I wouldn't leave a high pressure for a patient with asymmetric pressures, even if it's not too high. Because if one eye has a pressure of 25, no matter what the CCT, and the other is 13, something's not right there. But for these equally high pressures in an otherwise normal patient, yeah, we can watch.
Yeah, and the other thing is asymmetrical IOP matching the asymmetrical disc cupping. And that is really shows you, although visual field is completely normal, OCT is completely normal, that patient has glaucoma. It just hasn't shown yet, and you do have to treat those. Yeah.
That's exactly why I'm a bit frustrated, because we know very well that actually the discrimination, the possibility of discrimination of the tests we have today is certainly better than what it was 10 or 20 years ago, when we were just relying on the visual fields and we had to have just a visual field damage to say that they are glaucomatous. And then the OCT came, and we saw that all these people who had pre-perimetric glaucoma, and it's probably happening. I'm discussing that, okay? I'm not arguing on that. That it may be that 10 years from now we'll have another test where we see that pre-OCT patients were having glaucoma and we couldn't detect them. And so shouldn't we be a bit safer by saying, let's bring the pressure down to those who have started having genetically high pressure, because these OHTs will end up one day to be
Well,
I'm sorry,
don't
but
think-
are you suggesting that we should be, I'm sorry, I'm a little bit confused, but are you suggesting that we should be treating everybody with a pressure above 21 or 22? Is that what?
No, I think he's saying OCT abnormality.
No, no,
Is that
but
right?
No,
No,
no.
I'm saying whether if they have the pressure above 21, we should closely monitor, but 21, 22 sometimes can give big damage, we know that, okay? But it's not the regular thing. But 25, 26, what is the probability that this guy will give you some
We
damage
have
earlier?
evidence on that.
Okay.
So the evidence suggests that we should not be treating everybody with a pressure above 21 unless they are at high risk of getting glaucoma, and that risk is based on risk factors.
Okay. Excellent.
But I think you do, there's another lady that asked a question there. I just want to add on one thing that you say earlier. I think there is a problem that a lot of practicing ophthalmologists do use OCT alone as a guide whether to treat or not a patient. And I'm quite wary of that. I think OCT abnormality can show up in high myopic patients and also other patient tilted disc. And as long as the visual fields is not matching the disc, there's no risk factor. Pressure of 24, abnormal OCT, so what? You know, I wouldn't necessarily treat it just because they have abnormal OCT. OCT is not the ghost, not the sort of thing that is 100% accurate as we think you think they are. So there will be a lot of limitation about OCT. Do not use OCT as a single thing to decide on whether to treat OHT patients or not. That would be my view. You have a question there?
Thank you for the excellent presentation. I would like to ask you, how closely do you think that we should watch them? Every 6 months or earlier?
For a patient with
OHT.
Just the patient you referred.
Right, okay.
Under 30.
For a
everything-
patient who does not have glaucoma, I think it makes sense to consider the general risk profile of the patient. So a strong family history, a very high pressure, thin corneas, and maybe you would have given treatment, but let's assume you haven't and you want to monitor the patient. Then I think it would make sense a high-risk patient to be seen in about maybe 6 or 7 months, whereas a low-risk patient can be seen yearly. Our protocol at Moorfields for ocular hypertensives who are not very high-risk patients and therefore are not treated is a yearly test for 5 years, and if nothing changes, we discharge them. Of course, if the pressure goes above 30 or if something changes in the meantime, we treat them.
Thank you.
Yeah, I think sometimes we do have a profile now in St. Thomas's to see patient 2 years later rather than 1 year. And I think a lot of those cases, pressure 24, it's like, why are we seeing you so often? And particularly, and also you have to think about what tests you want to perform each visit as well. In those patients who have complete normal visual fields, pressure is maintained 24. I mean, do you want to waste visual fields resources on those eyes, or do you just want to reserve the time for more advanced glaucoma patients who are, advanced and progressing? So think about the resources. Do they need? It's debatable whether they need visual fields every year as well, if the rest of the eyes are pretty much stable.
Yes.
Sorry, no.
That's all right.
No. I wanted to say that clinical practice changes and many practices changes, and there is even discussion about the fact that we are now more prepared to accept progression in patients with glaucoma if we think that this progression is not going to impact their vision-related quality of life. So not only are we not treating everybody with ocular hypertension, but we are, in some cases, we are even allowed to be less aggressive with our glaucoma patients because people are now living a lot, they live long. So people can have even glaucoma, established glaucoma and higher pressure, but we're not aggressive because they are 85 or 90 and they are not at risk of losing vision. So yes, clinical practice is changing.
And particularly add to that is people whose glaucoma defect is not in the central scotoma. So
True.
they're less likely to cause any impact or significant impact on their life, visual acuity wise. So in those cases, you can just watch them rather than be too aggressive. But conversely, if you have a patient with a central scotoma, even if the MD is -4 or -5, you really make sure you control that glaucoma well, because if they progress, they will suffer catastrophic loss of vision.
Okay.
Yeah, 2 questions. As retina specialist, I see a lot of highly myopic patients, and some of them, they do have glaucoma. We do know that the reliability of the imaging, especially OCT, but visual field as well, is quite low. Is it a waste of time of monitoring them with OCT, or you need to, and if there is a baseline which is abnormal, but you can't quite determine whether it is glaucoma or it is the degenerative changes, can you use this as your baseline and then monitor the progression, or what's your practice?
Okay, so for the myopic patients, first of all, we know very well, especially from the Japanese studies, that there's a large group of patients with myopic discs which look very glaucomatous, and they're not. And they have been monitored for many years and they don't change. So not every myopic disc is glaucoma. But the paradox here is that myopia itself is a risk factor for glaucoma, so you are more likely to have it. In these cases, I can think of 2 possibilities. The nerves which were so dysplastic, with so big PPAs, that the NFL fiber layer around the nerve is not really useful, because there is no retinal nerve fiber layer there. In these cases, the ganglion cell layer complex is very useful, especially for these cases, because that's not affected by the dysplastic changes in the nerve. But there is a group of patients where the tilt is the disc is very tilted and very difficult to assess. but the retinal nerve fiber layer is intact. And in those cases, I personally find it very useful to do the RNFL OCT and monitor them with that. But for these patients, I also do the visual field as well. So for these patients, I would like visual field, retinal nerve fiber layer, OCT, if they don't have this huge dysplastic like staphylomas, and if they do, I will rely on the macular changes. But even these patients can have, non-glaucoma patients can have some defects which do not change over time, and that needs to be taken into consideration. But I must admit, I have a low threshold for treating.
Yeah, I think that's important. If you have high myo pressure 24, it's very difficult to assess the disc whether it's normal or abnormal. So I tend to view on the slightly aggressive side, but discuss that with the patient, saying that we're not 100% sure, but being higher risk of glaucoma because you're high myope, if it was me, I'd probably have treatment. And I think it would be a reasonable thing to share your, sort of lack of knowledge in the area with the patient and leave patient to choose whether they want to be treated or not. I think it's completely up to them. But monitoring them with visual fields and OCT, likewise, I completely agree with the panelists say that if you have a PPA that's encroaching where the scan ring is, there's no point in doing that. That's going to give you a false sort of data for information for monitoring the progression. Yeah.
Again, for funny-looking discs, glaucomatous-looking discs, and all there is to it is just large optic discs, which are very obvious, both in your examination when you measure it with your lens, but also in OCT. You see 2.5 discs. They look really cupped, and opticians get worried, and everybody may have a little bit of a borderline pressure, and everybody wants to treat them. That's another pitfall on imaging that we'd like to highlight. And another issue of the funny-looking discs, and based on a personal experience for the patient who had high myopia, peripapillary atrophy, seriously tilted disc, and baseline OCT in the region of 50s or 60s microns on the average RNFL, pigment dispersion, high pressure, low central corneal thickness below 500. Obviously, she needed treatment. We started treatment, very difficult to monitor. And she was not very good with the visual fields either. She wasn't getting panicky with the visual fields. She was very slow. She said, I'm always very slow on my responses. So another trick perhaps in those patients, apart from the ganglion cell layer, which is a very valid point, is to do not the standard visual field on Humphreys, but enhance, do a much brighter stimulus and much lower, slower pace so they can handle it a bit better and at least get a baseline from that with them, and then monitor it, of course, with the same protocol and see if you get. Would you do any of that?
I think that especially for diagnosis, it would make sense. It would also make sense to do a 10-2 visual field, especially for these patients where you don't know what's happening. But I would argue that if you decide to change the settings, which we do sometimes, everything that we know about the progression algorithms don't apply anymore, which means that, yes, you can change the stimulus so the patient can see it, but what you'll be seeing in the follow-up exams, you'll have absolutely no idea if it's variability or if it's change. I'm not saying you shouldn't do it, I'm just saying that it will be very tricky to monitor these patients this way. You do, and you also get it if you do 10-2, but it doesn't apply. It's not reliable. Anders Hale himself says it when he developed the algorithm, because the mathematics behind it don't apply.
Okay. Panagiota?
Just one more question that I didn't. A very common scenario in Greece is to have patients with borderline intraocular pressure, maximum treatment with or without Damox, and then the general sort of ophthalmologist tries to play around and change the cocktail. And is there any rationale at all in this, or we should straight refer for surgery?
This is, I think Wendy Franks had a talk a few years ago. Based on the number of combination drugs they are available, a number of types of each class of medication, I think if you change the combinations or change strength every 3 months. You probably have about 12 years before, and in that time, patient would have gone blind pretty early, in halfway, somewhere along this line. So be very careful about playing around with the combinations of various types. If it doesn't work, it doesn't work. You know, you've got to think of alternative, I think.
Except, of course, unless it's a steroid response. Yeah, and then you can wait. But I do agree with saying that it doesn't make sense to try a lot.
Panagiotis, let's say that you want to come back in Greece, good or bad, I don't know, and you want to have your private practice here with us, and you don't have enough money to buy visual fields and OCT.
That's absolutely certain if I ever come back, yes?
Yes. So, what will be your choice, a visual field or an OCT?
I personally think
I know the limitation of OCT. We have the floor effect. We cannot monitoring the patient with advanced glaucoma. But do we really need to monitoring these patients? I mean that the target IOP should be the lower the better. So what will be your choice?
Purely for the purposes of glaucoma, I would prefer the visual field because the visual field is a better reflection of what affects the patient's life. The disc and visual field correlation is not very good. You may be seeing OCTs which, even if they are abnormal and it's true, what does that mean for the patient? What does that correspond to? So, you see, unless you have a visual field to measure your patient's vision, you have absolutely no idea what this glaucoma is. You don't know if it exists, and if it does, you don't know what it looks like. So you cannot set a target, because one of the things you need to know to set a target for your patient, because you measure target pressure, is how bad the glaucoma is. The disc cannot tell you that unless it's really bad.
Okay.
And in that case, you don't need imaging to watch the disc. So if I had to choose, I would always go for the visual field.
Okay.
Yeah, I think I'll choose the same as well. Visual field is probably, if you're going to have one thing for glaucoma, visual field is probably the essential part. We're going to talk about a few cases now, and challenging cases. I'm just going to talk about one case quickly, and then Pan will got a few more cases to discuss. And it's a 14-year-old with JCA, uveitic glaucoma, and the left eye's been blind since she was 16. And then they had a left barbell tube implant. I think it's right eye blind, she was 16. Left barbell tube implant, 250 at 2014. Since then, since the barbell tube, she has consistent left hypotony. Hypotenuse maculopathy. Vision was 660, IOP was 6. I think I got it right and left set up. So what happened is that this is a patient with JCA. After a Barbell 250 implantation in the eye, on the eye, the pressure has been 6 with hypotenuse maculopathy. Yeah? What do you do? Any suggestion? So pressure is controlled, but it's too low. Barbell tube, what would you do? Any comment, any suggestion? What might I do? No?
Is the supramid out?
Yes, supramid is out. Yeah, supramid is out. I think a course of steroid, yeah, that's a possibility. In fact, no, she's been taking steroid for a long time because of JCA, so they didn't think. And there are other medications that's supposed to increase the aqueous production, but they're really not, they're not very useful at all. They don't really improve significant amount of aqueous production. So I simply went back, decided to tie the tube. I mean, that's just tied it. You can see how soft the eye is. And so I tied the tube, and this is actually a separate case of a patient with supramid. I tied with 9-Prolin and to do that. So what happened is after I tied the Prolin, pressure went up to 26. So what the hell do you do then? Pressure back and drops.
May I ask, why not put a supramid back in?
Oh, sorry. This one actually, well, supramid back in is difficult because you have to think that with a supramid, you have to do it up internal.
Yes.
for a start. Then you have to say, does it guarantee you a limited flow? There's no guarantee, either a complete occlusion or partial occlusion. So in this case, sometimes I tie the Prolin suture, but I titrate it. I tie once, I check the pressure. This is what I did. Prolin, I then check it with the eye care once, and I want to try to see whether I can get the pressure to the level I wanted at 12 or 16. And unfortunately, despite my best effort, the pressure went up again to 26 after surgery and back on Diamox. So what would you do then? Any suggestion what would you do?
Would you do any slits as the tube further up?
Yeah, the problem is you're going to have to open up the peritomy. And again, I published on the things show with sleep many years ago. It's very unpredictable. Sometimes it flows, sometimes it doesn't flow at all. So you kind of left with this dilemma. So what do you do? Any other suggestion? Again, I don't think steroid in this case will increase the aqueous production too much. There is a bit of aqueous production. So what I did was I tied the valve. I didn't touch the valve at all. I put an armored valve in. Make sense? Now, the reason why I do that is because armored valve does have a valve, and it does control the pressure at the set IOP level. But you do have to make sure that it worked, okay? If it worked, I test all my armored valve before I implant it in the eye. And I don't want to show you the video here, but you test it, make sure they open and close the set pressure, then you implant it. The reason why armored valve worked in this case, and she ended up doing really well now, because she had armored valve instead of bowel valve, because armored valve is maintaining pressure about 10, her hypotenuse maculopathy is gone, and she's doing really quite well. So what I'm trying to say is that in this kind of juvenile chronic arthritis, severe inflammation, they genuinely have a very low aqueous production in these cases. So even a bowel valve 250, the plate is too big for them. Maybe one could consider a Molteno 150, it's about 144. That may be reasonable, but I don't have Molteno, so I decided to use Armored. And Armored when it works, it can maintain a minimal pressure. In this case, it works quite well. So always think about that as a possibility of armored valve in those cases with severe uveitis, okay?
Can I suggest an alternative?
Yeah.
What about putting the supramid ab interno,
Yeah.
tying off the tube at the front with more than 1 nanoprolin,
Yeah.
and then do suture lysis at the slit lamp
Yeah.
if the pressure goes up? So you have a restrictor all the time, so the pressure doesn't crash, and then you can control the pressure by lasering the sutures.
You are absolutely, it's occasionally work. What I was trying to do is not to having to go back too often. The problem with this kind of supermid, as I say, is unpredictability about it. You can put a supermid 8 millimeter, 10 millimeter, you have no idea whether you're going to get a pressure of 40 or 4. And usually it's no flow at all. Usually it's quite high pressure if you have a high with supermid in there. So it's the unpredictability of it all. So I was trying to be, trying to titrate it with a Prolin suture tie, but it didn't work. So this is the armor valve that I put in on the separate side, and it does work quite well. So another case is a similar sort of case of a much older gentleman, 45, with congenital cataract, aphakic glaucoma, blind one eye, right eye, multiretinal detachment repair, psoriatic uveitis. Pressure when it came to me was very, very high. Had 2 express implants done in Hong Kong. Pressure was 30 when I saw him with pressure on despite Diamox. So in this case, what would you do? So this is a case with, you can see how scarred the conjunctiva is in previous express im shunt twice. You can see completely scarred. And inferiorly, there is a plum from the previous retinal detachment repair. Okay? So this is the problem that you face with. So what are you going to do with this case? On the eye, high pressure, and very scarred conjunctiva. Any suggestion? Diode. Possible. I mean, you have these 3 options. Short-term, work very well. If you revise it, it will work for 3 months. It will scar again. Diode, possibly hypotony, because this is an inflammatory eyes. And my worry is that you may push it the other way into a hypotenuse eye. And tube surgery, are there enough space? So I actually consented the patient for diode and tube, if I can find enough space. And when I went in, having sort of spent about 5-10 minutes thinking about what I'm going to do and checking the conjunctiva, I decided there may be enough space in one quadrant to put in a small Barbell 250. And that's what I do. In this case, it's always quite useful to do a subconjunctiva dissection using lidocaine or BSS, whatever you want to do. That helps you to mobilize the conjunctiva subsequent space, and you can then put a tube in the area. So I put in a Barbell 250 in this case. I didn't want to use 350 because of the history of uveitis, or psoriatic uveitis. And so this is much easier to put in. And again, he's done very well since then from a pressure point of view. The pressure has been well controlled ever since I removed the supermid suture. And so this is really just 2 cases to highlight when you have uveitis, severe uveitis, and when you have scar conjunctiva. Think about those, think of them as a possible low aqueous production. So if you want to do a tube surgery, think about armor valve. It can be quite useful. Or if you don't have armor valve, you only have Barbell, I would definitely put a smaller one rather than a big Barbell. Do you use armor valve or Barbell here? Both. Great. So you have both, yeah. But armor valve, but you do have to test armor valve before you implant it because sometimes they don't work at all. And we published it a few years ago. And that's it, actually. Pan, do you want to take over?
Sure.
Yeah.
Can I also ask you what do you think about Zens in uveitic patients?
Yeah. I don't like Zen at all because Zen in my hand seems to all fail very quickly. The good thing about Zen may work, the reason why Zen may work in uveitis is that acute uveitis with high pressure may be a temporary thing, okay? It may be a combination of inflammation, combinations of steroid use at a time. If you can put a Zen or any kind of tube in, even if they only function for 3 months, it may be enough. It may be fine because by then the inflammation is gone, they're not on steroid, and it doesn't matter what you put in at the beginning, right? So it is important to think about why Zen may work in this case. I think some people have good result, and that is because of the temporary nature of the uveitic glaucoma, rather than the Zen itself being successful long-term in terms of draining. That's my experience. Okay, thank you.
Yeah, I have 2 more cases that I would like to discuss with you. I'm not sure if they're exciting enough after the revisions that Schenk showed, but these are again in the field of monitoring the patient. So a 67-year-old female African lady who is labeled as primary open angle glaucoma suspect. When I saw her, that was the diagnosis. Her maximum untreated pressures were 28 in the right eye and 22 in the left eye, and she has a good pressure on latanoprost. But she had a branch retinal vein occlusion in 1998, and she had laser for that. Her mother and grandmother had blindness from glaucoma. So this is a very high-risk patient. This is the nerve. So these are the discs. First of all, anyone would like to comment on the discs? I mean, you cannot see them very well, but any comments on the discs? Excuse me? There is yes, it's true, there is some asymmetry. The right eye has, they seem to be equal in size. The right eye seems to have a larger cup than the left, but isn't rule is obeyed here. The inferior rim is thicker than the superior rim, than the nasal and the temporal. So at least just by looking at the nerve, it doesn't look to me like a glaucomatous nerve, just by looking at it. Of course, it's a 2-dimensional image, but still, the left eye probably seems to be okay. So the label of POAG suspect probably makes sense here. And now this is her RNFL OCT. And as you can see, there is an area here highlighted as abnormal. Would you say that this is very suggestive of glaucoma?
Could be the BRVO. Do we have an OCT prior to the
Yeah.
BRVO?
No, we don't, because she already had that. That's what I thought as well. So I thought that's not a true RNFL defect, because that's where she has the laser. So obviously the retinal nerve fiber layer is defective, but it's not glaucoma. And that's one of the things we always need to remember, because we need to check the rest of the retina. Okay. And this is the defect, which, by the way, of course, is consistent with the BRVO, but it could be glaucoma as well. So just by looking at the defect and the OCT, you'd say that that's glaucoma. Fine, okay, so we all agree on that. And the left eye seems to be all right. And this is the visual field over time that she had. So we've been monitoring for a long time. But this, just by looking at it, which is just the grayscale, so not great, does anyone think this is getting worse? Does it look worse? It looks worse to me. Yeah? That looks better than this. So,
It looks worse from 2017 onwards when she had the BRVO.
she had the BRVO in 1998. No, I'm sorry, she had it before she came to us. So I thought, why would a BRVO defect getting worse? Is it the scars expanding? Dr. Trenos, is that it? Could be. Yeah, I thought maybe that. But that's exactly what I thought, okay, here it makes sense to check the GPA analysis. So this is what I'm getting from the Humphrey. I have the two baselines, which are slightly unreliable, but okay, decent. I have the new visual field, where there are a couple of areas, but it doesn't really look that bad, does it? It's not as worse, according to the machine, as I thought it was when I compared the first and the last one. And her VFI is relatively flat. If anything, she's not at risk of losing a lot of vision in the next 5 years. So with a pressure of 17 and this disc, I thought I shouldn't be doing anything. But somehow I didn't like it. I don't know if that makes sense. You know, we do all the tests and then you say, yes, but I don't like it. I don't like that. So I started messing around with the field. And I noticed that some of the fields she had were Sita fast, and some of the fields that she had were Sita standard. And you're not supposed to mix them up. But when you have a networking system, everything goes there. So you need to take that into account. So I went into the machine and I separated the standard from the fast to see if I would get something else to prove my point, and I did not. So this is a relatively flat line here, nothing highlighted when I separated the fields, and again, nothing here. The patient, though, I must say that the patient, because she was because of her family history, was saying, I'm getting worse, my vision is getting worse, and I was a little bit affected by that. I didn't do anything, but I decided to watch her a little bit more closely, because somehow I just didn't like how the field looked. But this is an example of how useful this can be. So this is my first case. The second case, yeah, right. The second case is a 77-year-old male with primary open angle glaucoma and pressure up to 20 on 3 drops, 2 bottles. Okay, and this is the OCT, this is the disc. So the right optic nerve is clearly glaucomatous, the left optic nerve classified as normal. And this is the visual field. So here's the problem here. So these visual fields at the top are a lot better than the bottom. But if you look at the VFI, there seems to be some space between the two. And then I realized that these were like some years apart, because the patient disappeared and then came back. So I wasn't quite sure what's happening here. It looks like a normal, like not very suspicious progression there. But that's going down at the same time. So you cannot just rely on this and say there is no definite progression, my patient is fine. You have to consider other things as well. Plus, the pressure is high now. It's not good. The left disc, very similar. So nothing, you don't have a lot of tests to get the projection. Nothing very typical here, no progression there, but the pressure is high. Of note, this patient didn't have any problem at the macula. His vision was fine, and we did a macula OCT, and presumably we were able to interpret it, so he was fine. But one of the things that's important, I want to say with the visual field, when you do the visual field test, there is a little cross, and there's a little target above that, yeah? And we say that you must tell your patient initially, please look at the cross, because that's how the machine detects the blind spot. And then the patient is supposed to lift the gaze at the spot to do the field. If they don't, you're not going to get this clear-cut visual field defect because your middle line will be here. So basically, that could be a visual field test not done properly because the machine is not fixating, because the patient is not fixating at the same, at the right spot. And having spoken to this patient, I can imagine why he said, eventually I did a trubby for him, and he said, where am I going to put the chloramphenicol? I said, please keep it in the fridge. And he said, I don't have a fridge. So anyway, okay. So no big change here, but I realized that there were a lot of tests because we had different machines in the room that were not connected with the Zeiss platform. And when I put all the tests together, this was the real visual field there. And similarly, in the left eye, this was the real progression. And obviously, he needed operation in both eyes because he was already, and he had it, and he's doing very well. But the learning point from that for me was that if you don't have all the visual fields together, especially if you're working in a hospital, make sure that all of the machines are connected to your database. And if you are using different algorithms to detect progression, keep in mind that different algorithms may give you different results depending on what you put into these algorithms. Because this is software. It will produce the outcomes depending on what data you feed to the software. So from now on, I'm checking both Medisoft and the Humphrey visual field. Thank you very much.
Okay, so another marathon is over. This brings us to the conclusion of this revision course. I would like to thank our exceptional speakers, amazing talks. I would like to thank our sponsors, and I would like to thank you for all your patience. I hope you enjoyed it as much as I did, and hopefully we're going to see you again in a couple of years' time. You can take your certificates from the reception, and you have to know that the whole meeting will be uploaded online. So you have to go through the Ophthalmica website, and then all the talks every day will be available to download them. Okay, thank you.